Good afternoon.
Good afternoon.
My name's Hermita Nichols. I'm a certified occupational therapist assistant. Can everybody hear me okay? I can talk louder.
Yes, please.
I'm good at yelling at my kids. I've been a therapist for pretty close to 20 years, and I've been at Jackson County this time for 16 years. Everybody has to have a this time at Jackson County.
I had 4 this times.
You had 4 of them? So see, everybody has to have several go-arounds at Jackson County. My degree is an associate's degree. I got my degree at Cook County in Gainesville, Texas. I went to school at TWU, Texans Women. That was the sister college of Cook County. So I actually went to school at TWU and took all my classes. TWU has an OTR program. They now have what they call a bridge program for CODAs, such as I, to bridge over and become an OTR. I think they started that maybe 3 years ago. We do have some people at Jackson County that are doing that right now.
Can you tell us what CODA and OTR stands for?
Yeah. I am a certified occupational therapist assistant license. Like I said, it's an associate's degree. And then there's occupational therapist registered, where they have a bachelor's or master's degree, where they go into the patients and they do the evaluation. They evaluate the patient for their limitations, and just like a PT, physical therapist, they evaluate what the patient's functions are and limitations are. Then they come up with a plan. They write out what the plan is, their goals. And then they give that to the PTA, Physical Therapist Assistant, the same associate's degree that I have as a CODA, as a Certified Occupational Therapist Assistant. So we're underneath the PT and the OTR. Should take us 2 years to get our degree. Sometime they have some of us with our basics and everything else might take a little bit longer, and we implement the plan and we try to have the patient reach those goals while they're in the hospital. So sometimes they're in the hospital for a couple of days, sometimes they're in the hospital a little bit longer, and we can reach those. Now they used to, year and a half ago, have what they called a SNF. If any of y'all heard of SNF, skilled nursing units, those no longer exist. They put patients there for several weeks, sometimes 2-3 weeks, sometimes, to get them stronger, get them better, figure out where they would go before they went home, nursing home, and they would get their therapy, figure out where they're going to go and stuff, depending on their insurance and stuff. Now, New World, Obama world, they have what they call swing bed. This is all exciting and new. It's been going on for about a year and a half or so. We have it at Jackson County. Their stay is not much more. They have to be in the hospital before they go into swing bed. They must be in the hospital 3 nights in acute care before they swing. So we have to go in and explain to the patients. Basically, it's all paperwork and everything. The patient really doesn't swing. They stay in the same bed and everything. It's where they get stronger and they get their therapy and everything else. And we get to work with them as therapists, hopefully to get them better and stuff. But the deal is, they really don't get to stay there long for us to get them better. So they want us to work with them, get their goals, and get them in and get them out wherever they're going. So sometimes they're only there like 2 days, 4 days, and then they're wherever they're going, you know. Maybe the longest I've seen them stay is a week, and we're kind of lucky if they stay that long to work with them. But we have seen a lot of progress, you know, with them at that time. So that's kind of what we have at the hospital. It's like, you know. So when we get a knee patient, and it's mainly our orthopedic patients that we see the most progress with, that after they're done with their acute care and they have their insurance and they can swing, and we get to work with them for 4-5 days before they go home, or, excuse me, and they go, we have a couple rehab places here locally that they get to go to, and we get them well enough where they can go there. They're pretty much ready to go there, and they're motivated enough to get their rehab. So we have them prepared and ready enough and up and moving to do that. Okay. Today we're here to talk about back safety and lifting techniques. You're just starting your career, and you only have one back. So Ms. Phillips wants you guys to learn how to use your back properly and safely. Everybody here, I'm sure, might think that they know how to lift. I'm sure you've lifted quite a bit at your home, and those that have children. We all have developed bad habits, and I'm here to show you and let you know some of the bad habits that people have learned over the years. Hopefully maybe you can learn how to break some of those habits and learn some good habits today and use them in your career. It's up to you what you learn today, if you implement it during your career or not. Okay? So in your book, we're going to talk a little bit about some anatomy. I'm sure you've had your anatomy, and we're going to talk about that. It talks about the guidelines about lifting techniques. Okay, the first thing you need to do is plan your lift and know what you're going to do. Know what you're going to do with that patient, wherever you're going to move them, your box, your object, whatever you're going to do with it or anything. Make sure that you have things ready. Your wheelchair, your potty chair, whatever you're going to do or anything like that. Okay? Have the door open to your car or whatever, your groceries, your trunk open, whatever. Just have things ready, whatever you're going to do. Think things out, plan it out, whatever you're going to do. That's the first thing. So plan your lift. That's what you need to do. Keep the curves. What we're talking about there is your back. You have 4 natural curves in your back. Your cervical, your thoracic, your lumbar, and your sacral. Okay? The thing about that people don't realize is when they look down at something, you've already broken the first curve. Okay? Now, I didn't say you can't ever look down. You can look down at what you're going to pick up, but when you have the weight in your hands, that's when you're breaking the curve. Okay? So when you have the weight of the object or whatever, you need to keep your head up and keep the curves, okay? So that's the main thing. So if you have some weight or whatever, you need to keep your head up and keep the curves, okay? Maintain a wide stance, okay? There's several different stance. You have your diagonal stance, parallel. You just got to figure out what's comfortable for you, and I'll show you over there when I demonstrate some different stance. And I just know what's comfortable for me. You got to figure out what's comfortable for you guys on a stance. Keep the object close to you. When you have an object, I usually, when I do back safety, I usually give somebody 5 pounds or give them a book or something. You guys can do this at home or something or whatever. And take a book and hold it out at the end of your hands. Whatever you have at the end of your hands, be it a ream of books or whatever, and you hold it there just for a short period of time. That, you'll feel it here in your neck and your back. That weight, that 5 pounds, multiplies by 10. So in a while, that's going to be 50 pounds of pressure on your neck and your back, and you're going to feel it. So you want to hold that close to you. Usually, have you ever heard of, ask them to have the patient give you a hug? You want the patient close to you. Imagine this patient, for instance, I don't know how many has worked in nursing homes or hospitals or stuff. You know, you get a patient and they're afraid and they're resisting you, and you're lifting them up from the bed, and their hiney's up from the bed, and they're pulling back because they're afraid, and you have that distance between you there. They're 100 pounds, okay? It's 1,000 pounds of pressure that you're lifting up, and it's on your back, okay? That little old lady isn't a tiny 90-pound weakling anymore, you know, on your back, okay? All right, so you want to keep them close. You ask them to give you a hug, and you want them to hug you around your waist, okay? All right. As far as the back goes, if you look in here in the handout, and I know you guys had your anatomy, but I want to let you know the layers in your back. If you peel that away, those muscles, you know, you have your big muscles in your back. Well, the thin ones along your back, okay, those aren't really made for lifting or anything, okay? Those are to help with our posture, okay? Because they counteract your abdominal muscles, okay? All right? If you look, that's not the best picture, but on the next page, the muscles on your legs, those big thigh muscles, those are the ones that you want to use to help lift with, okay? You want to lift slow, smooth movements and use your leg muscles, okay? That's what you want to use, okay? Not your back muscles, okay? You want to avoid the spinal torque, okay? People have a tendency when they pick something up and move something all the time, they have a tendency, especially when it's something nurses in the med cart or whatever, they're moving something from here to here, or they're moving meds for the patient or something, they have a tendency to do this a lot. Picking something up from here and moving it over here. They're moving their medicine or whatever they're doing. Well, if you're going to work a 12-hour shift, 4 days a week for a month, you know, after a while, and you do that for several years, after a while, you kind of wonder why I have a strain back here. You know, I start hurting after a while. You know, I've been there 16 years, and man, I just hurt, you know. So the rule is avoid the spinal torque. You need to move your feet, your whole trunk, with the object. Whatever even if it's a half a step, you need to move your trunk with the object. Okay? I know it might take a few seconds, but you got to think of your back, okay? So you need to move with the object, okay? And you need to ask for assistance when necessary. After you do all this and you get to a point with something that you see that you need help or something with, whatever it be, whatever the help might be, either you get another person to help you, mechanical lift, a Hoyer lift, or whatever it be, you need to ask for assistance. In this handout I gave you, it shows some different do's and don'ts as far as lifting. You can see on the page or whatever. Workstations, poor workstations that people have, poor mattresses. If you have a poor mattress and you don't sleep well, that affects your back. You need to look at your mattress, okay? Accidents, we all have, there is acute injuries. I'm not saying that people don't get hurt with acute injuries for back problems, there is. But the whole thing at work, most work injuries are the repetitive injury that happens to a back over a long period of time with years, okay? Loss of flexibility. Really, the United States, as far as overall, we really have poor flexibility as we get older. So our overall physical health is not that great. You guys know that. You're in the health field. So I'm preaching to myself here. Okay, there are more than one lifts. There's several lifts. If you turn onto the page that has, there's a tripod lift. And if you guys want me to show you these later, I can. That's for something really, really heavy. And you can see the stages here, how to do it. There's called a golfer's lift. That's if you're picking up something really, really light. That's how you can put like a lock on a wheelchair. It's the opposite hand of the opposite leg. You support the one and you put the other one on. A kneeling working station. You should be doing that one when you get down to like get something out of a med cart, get down to work with a patient in a recliner. If you're doing something with them in a recliner, with her in the, in a chair or something like that. The straight leg one, I hardly ever use that one. I don't get stuff out of my trunk of my car. And the squat lift, that's when you're picking up a suitcase or something like that. The one hand is on the knee and the other hand's on the handle, and you push off with the knee with that one and you lift up. You use that other hand to push off the knee. This handout I think is the best handout. I really like it. It shows all positions on how to get someone up from a chair, from a stretcher, from a wheelchair, from a bed. It's really good. How to walk somebody with a walker, how to ambulate them with a gait belt and stuff like that. But it also shows what I was talking about as far as your standing position, your posture. Over here on the, well, it's my left side, over on the left side of the sheet. How you need to keep things close in the posture and everything. So I really like that sheet. And on the back, it talks about transfers with one person and two people. And we're going to go over that over here on the bed. We're going to kind of simulate it. And you look at these, and then we can go over them quickly. And if you have any questions about them, I'll be more than happy to, while I'm here, to answer any questions about these. Let's see, what else is it? Oh, in the back here, I just put about how to use a walker, and since I'm OT, I put information about transfers with ADLs and other things, car transfers, bed transfers. You know, OTs, we have to put stuff like that in there. That's just us. So if there's any questions, I'll answer any questions. Otherwise, we're going to go over here.
Does anybody have any questions?
Not yet.
Okay.
Linda told me that she didn't have some of this equipment. I don't know how many of y'all have seen some of this before or not. This is just a standard cane. All this is adjustable for height and stuff. So this is just standard walking cane. Okay. So you would do the equipment, and then the bad side, good side. So that's how it would go. Okay.
You'd push the cane first in front of you, and then you'd do the bad side, and then the good side. Okay.
This is called a quad cane, yeah. Because and it's more stable for some people that need that stability for them. That helps them. They sometimes tangle it up and get it going this way. You want it this way. Then you have a standard walker. Okay, and sometimes you'll see tennis balls on the bottom of them or wheels on them, which really helps them sometimes with their mobility to get around. Okay, so, and it uses less energy on them sometimes if they can just roll it instead of lifting this thing up all the time. You know, it expels a lot more energy for them. So you want to go, well, if they have a bad leg, you want to go walker, bad leg, good leg. If they're, you know, a surgical patient or something like that, try to get them to use their upper extremity. You know, if they're a hip or a knee patient, try to get them to use their upper extremity if they can. Okay, I'll usually leave this in here. Now you have a Hemi walker. Okay, and this is another one that gets twisted up a lot too. Okay, this handle, if they're sitting down on a chair or something like that, they can kind of use this sometimes to help push them up, and then go up here if they need to. But they'll get this kind of twisted up on them sometimes. So, and sometimes they'll put it in front of them like that.
And then trip over it.
Yeah, it needs to go on the side. Okay. Another thing is, I made sure that all these were real sturdy and had all their little stopper things on them, because we have them at work sometimes and they're not. So you want to kind of keep them, make sure that your residents or your patients, whatever, have them in pretty good conditions and stuff, because if they get unsteady or not in good condition, you know, it can cause, you know, unsteadiness, because they're unsteady already. You know, you don't want to make it worse. I don't think too many of your residents are going to have these, but I just brought them along to show you. These are adjustable also. This really isn't my height, but I wanted to let you see these. The way to check these is, it should be 2 fingers, okay? There is a nerve here, your brachial plexus. You see people like hanging like on these all the time. If they keep on hanging on these all the time, or they're up too high where they're like, jacked up like this all the time, they can do some nerve damage to their shoulder here. So you really don't want to do that. I don't know how many weeks someone would be on this, but if they're on it too long and they keep on having that pressure on that nerve, hopefully the doctor wouldn't do that, but they could do so much damage that eventually they could maybe not be able to lift that shoulder. So if they start having problems with this shoulder and tingling this down to their fingers and start having problems with their fingers, they got some problems coming up their way. So what this is what you want to do is put this out and you kind of swing through it. And it's just a swinging. Of course, I'm swinging pretty big, but, it depends on, but it's just, you kind of just swing through it.
So you put your weight actually on your hands?
Yeah, it's on your hands.
Okay.
Yeah, and you just kind of swing through it.
Mhm.
So, but the problem with the walkers, I didn't show, but have you seen those people kind of walk the walkers? Yeah, you don't want them to walk the walkers. I'm sure you've seen everybody do everything wrong with those walkers. And the canes too, they drag the canes behind them. Oh, drives me crazy. But anyway. Oh, I really don't need it, I just,
Just for
yeah.
just for security.
Yeah,
Huh?
just in case, like, oh my gosh.
Hermina, how do you judge how tall a cane should be for a person?
Honestly, PT usually has them adjusted.
Already adjusted?
Yeah,
Uh-huh.
I really don't adjust that much, but they should have them right about. It depends on the elbow. You don't want the elbow really, kind of like that.
Yeah.
You know,
Okay.
their elbow comfortable and stuff. So that should be right about like that.
Okay.
But PT usually does all adjustments on they usually see them first and they have everything adjusted. I think home health PT goes in first too.
Okay.
OT usually goes in second. Speech goes in last, usually if they're ordered. It's just always been that way.
Okay.
But I think that's how it is. It's kind of like that. And they like to push everything out real far away. You want to keep them inside the walker. You don't want the walker out real far. A lot of it is really common sense, but they get in a hurry, And you've seen them walk out like this with the walker and stuff. And so I don't know why they want to push it so far away, but they do. Okay, have you guys seen these?
Yes.
Some of you have seen these. These are called gait belts. Okay. And I meant to bring another one, but I forgot it. They have the big green ones at the hospital with the handles. I don't know if they have them at the nursing home or so. They have the big green ones with the handles, and I think they even have Velcro. I don't know. But they're not my favorite. That's probably why I forgot it. But these have little teeth. You want to put it at the abdominal area because that's the center of gravity. Okay. You want it snug and tight. They say it's too tight. They'll gripe about it or whatever. But when they get up, it kind of loosens up. You want to be careful with if there's an incision, a peg, colostomy, whatever it is, you need to be careful, you know, what you're putting there. Your little ladies, you want to be careful with, you know, the breasts or whatever. You know, you want to make sure you're not squeezing.
Don't smash them into the
Yeah,
belt.
yeah. If they're alert enough, kind of ask them to help you move things out of the way. If they're really big people or something, and you need to, you can get 2 of these, and you can hook them together. You can hook them together if you need to. So, that's no problem. But the deal with this is, if something happens or whatever, you've got something to hold on to. If they lose their balance or anything happened during the transfer or something, you've got something to hold on to them as whichever way direction they're going. If they're going down, you got something to help guide them down. Don't try to stop them. You got something to help lower them down and without hurting you. You know, don't try to lift them up or something like that. So that's the deal with the gig belt or whatever. I don't know how to put it. If you're working at Jackson County and one of the things, someone goes down or gets hurt and doesn't have a gait belt on, not all the time, but some of the time they will ask you, did they have a gait belt on? And if they don't have a gait belt on and they feel like that they want to terminate you because they don't have a gait belt on, and that's the only reason, they will terminate you. So, I mean, because you sign, that's one of the papers that you sign.
So anytime they're walking somebody, they need to have a gait belt
They
on.
should have a gait belt on.
Okay.
And they're on the floor, and majority of the time you will probably only see therapy people using gait belts.
Okay.
But they're on the floor.
Okay.
They're available.
The students will use them.
So they're available. If you want to, I think they're like $12 at Home Health if you want your own. And these, not these, these are cotton cloth. We don't use these anymore. These are the ones we use. These are kind of like nylon stuff.
Mm-hmm.
Those Sandy Wipe, the white top ones, you can take those and wipe these down.
Oh, okay.
Dorothy ordered these. These are different. We can wipe these down
Good.
in between patients.
Good.
Not these. I don't know. We used to have to wash these in the washing machine. So anyway. So now I'll take somebody, I guess, and do a transfer. So this is a hospital bed. Okay? She's in a hospital bed. And I'm going to come in and get her up, and she's going to be a hip patient. Okay?
Okay.
All right. So we're going to do left hip since she's on that side. All right. All right. So if you have your hospital bed, you want to use as much of mechanical device that you can use to help you out for your back, okay? So we'll let them use their track, especially depending on their age. I work with a lot of geriatric patients sometimes. And if they're from a nursing home or something like that, and they're used to the head of their bed being up, or they're used to a trapeze bar. Thank you, sir. If they're used to a trapeze bar or something like that, let her use that stuff. But if I've gone in and seen her already some, I'm going to try to talk her out of using the trapeze bar. my second time I seen her, but yet I'll sometimes let them use the bed rail depending on how they're feeling and stuff like that. So you just gotta go in day by day and see how they're feeling. But what I try to do every day is try to let them use less and less of the equipment and use more and more of their upper body and their muscles and stuff like that. So that's kind of how I work it. So try to talk them into using as much as they can, okay? So Nicole? Okay, I'm Hermina, and we're gonna try to get up, okay? All right, so you had a hip done? Okay, so we're gonna try to get up. I'm gonna put my hand under your knee, okay? All right, so not only look at her body mechanics, but kind of look at my body mechanics too, okay? All right. All right, so there's a bed rail there, okay? I want you to kind of roll over on this side, and you can reach it with both hands, okay? Okay. Remember, this hip's sore.
Okay.
Okay, and you can come out here. All right, good girl. All right, now push up with this. All right, good deal. I'm gonna scoot out. I'm gonna lower this down. Okay, and take this down. Okay. So she's hitting the floor here, okay? Because you want it to scoot out to the edge till they hit the floor, and you're gonna support this until they hit the floor here, okay? All right. Typically, I stay squatted down on the floor, and they're lowered down enough on the floor that I can put this on. Okay, I'm gonna scoot on out to the edge. Okay. I'll come in. Okay. And push up from the bed if you can. Okay, lean in. Okay, let's stand up. Okay, we're gonna turn around. And go back till you feel the bed or the chair. Reach back and ease down. There we go. There you go, good job. Okay. All right, you can come on over. So the whole thing was, I didn't let her just sit down in the chair, I went down in the chair with her. Okay? That's the whole thing, you go down with them when they sit down. She didn't have to sit all the way in the back of the chair, as long as you get her on the edge of the chair, and then she can either scoot back, she was strong enough, she could have scooted herself back in the chair, but she went all the way back in the chair. That was the deal with that. Is there any other transfers or anything you guys?
A couple of weeks ago that a hip, we're not gonna put at a 90-degree angle. And she sat at a 90-degree angle both at the bed and then in the chair. Is that incorrect, or is that?
It depends on what type of surgery
Okay.
was done. Now, we have some docs at the hospital that are doing the frontal approach instead of the posterior approach. If you're doing a posterior approach, no, you don't want to do that. But they're doing an anterior approach now, and you can.
Okay.
So
Oh, wow.
it depends on what type of surgery is being done. So you
Okay.
need to look in your charts and see what type of surgery is being done. Okay?
Also, if it's a comp screw, it doesn't matter about the 90-degree angle,
Okay.
okay? Well, I'm glad they're doing that.
Yeah,
That's good.
yeah. I think it's Dr. Duncan and Dr. Pickett. Okay. It's a good question. Okay. Anybody else?
Any other questions?
Can I backtrack a little and ask a question?
Sure.
What's the difference between PT and OT?
The layman's easy answer is OT's upper extremity and PT's lower extremity.
Oh.
Okay, well that's just easy. No, really, seriously, that's kind of an easy way to explain it to some people. But OT, we really work on functional activities. We look at the patient holistically in their whole approach. We want to get the patient back to what their prior level of function was and have them do their daily activities and get them back. Let's say you had a stroke, okay? And you want to be able to go to the bathroom, okay? Well, PT will walk you into the bathroom, okay? They'll take you in the bathroom, no problem. But OT will make sure that you can get your pants down, okay? Get you on the potty, and make sure that you can wipe yourself, you know? So we do functional activities, okay?
Gotcha, thank you.
No problem. Sure.
Can you go through the different types of crutch gaits, like 3-point?
Crutch gaits. I haven't worked with crutches in years.
I'm confused.
I think what he's saying is like, we just studied that on our last chapter, and what you were doing a while ago, I think, was our 3-point gait, where you just used one,
Yeah.
like you had one leg and then 2 crutches was like the 3-point, and then when you slid through, like our slide through
Uh-huh.
on our gates and our books, was like when you have both feet up and you have your crutches and you like slide through your, you know what I'm saying?
That would be more of a PT. They do more. When we get a patient for same-day surgery and they want to do crutch training, they send an order through for crutch training for same-day surgery to train someone, and they send it to PT. So that's not really what OT does, because it's just a same-day surgery and they send somebody through like that. So I really, I can get that information to you. I'll be more than happy to find that information for you and send it to you tomorrow. I'm not going to blow you off, but
It's in the book.
I'll find it out for you and get it to you.
Does OT do any dressing changes, or is that PT?
That's PT. They do wound care.
Okay, but,
Now, wait, let me take
Okay.
that back. If it's like a hand or upper extremity or something like that, not saying we can't.
uh-huh,
Yeah, we
Okay.
do like hands and wounds, and yeah, we have done them. Yeah,
okay, but I do know that, from working at the hospital, that Hermina would get upset with me, but not really upset, but if I have my students go ahead and do a bath, she's coming a little bit later, and she wants the patient to do as much of their bath themselves as they can. So that again is talking about the functionality.
we're working on strength, endurance, problem solving. There's just so much in when you get up in the morning and you go into the bathroom or you go into the kitchen, whatever. Think about what you do in the morning to make your coffee. You have to sequence the problem. You have to